Hi, welcome to today's program. Hi, my name is Melinda Frost, and I work for the World Health Organization. I'm a technical officer for risk communication and community engagement under the infodemics management pillar for the COVID-19 response. Today's program is titled, What Must Not Go Unspoken? Gender-Based Violence During COVID-19, the Risk Comms and Community Engagement Response. I'm going to invite you today to hear a number of our speakers who come from both WHO, country offices, and our partners at UNICEF. This is a joint initiative. Today's program is a joint initiative with WHO's Infodemics Management Response Pillar and the Global Collective Service. The service is a joint initiative between WHO, IFRC, UNICEF, with support from the Global Outbreak and Alert Response Network, otherwise known as WARN. The COVID-19 pandemic exacerbates gender inequalities and risk of gender-based violence. Extended quarantines, curfews, and other movement restrictions have impeded access to services and for survivors, while at the same time increasing their risk of experiencing violence, particularly in the home. Risk communication and engagement strategies for COVID-19 need to address gender-based violence as a major public health problem. This webinar will examine gender-based violence in the context of COVID-19. So with that, I'm going to turn it over in a moment to our moderator for today. But before we do that, we're going to go into some polling and get your viewpoints and get your experience level on gender-based violence. So our first question is, and all you have to do is click on your screen, is have you observed gender-based violence awareness messages? Oops, I'm sorry. Gender-based violence response and prevention is considered an essential component of COVID-19 response in the setting I'm working in. If that's true, or if you strongly agree, answer at the bottom, agree, neutral, disagree, or strongly disagree. Give that just a minute. Okay. All right, well, the polls come in. Go ahead and vote in the next couple seconds. 5, 4, 3, 2, 1. Okay, well, this is some positive news that it looks as though most of the individuals said that they agree that this is an essential component of the work that they're doing right now in the setting they're in. And we have one more question for you before we begin. Okay, gender-based violence, whoops, sorry. Next question. Have you observed gender-based violence awareness messages in the COVID-19 prevention and containment activities in your community? Yes, no, or you're not sure? Okay, this seems to be a pretty easy one to vote to. Okay, we'll close the polls in just a couple seconds here. 5, 4, there we go. Okay, so it looks like the majority of people have awareness messages and the work that they're doing. So that's also some positive news. Okay, with that, we'll go ahead with our program. I'm going to invite Dr. Claudia Garcia Moreno, who's the unit head who is in addressing needs of vulnerable populations in the Department of Sexual and Reproductive Health within WHO. Claudia is going to moderate today's program. Thank you, Claudia.
Thank you, Mindy, and welcome everyone. Good morning, good afternoon, good evening, depending on where you are located. Thank you very much for joining us. I'm delighted to welcome this panel, and I think it's interesting looking at the poll that in the last one, about 60% said, 57% said they have seen some GBV awareness raising, but that means that about 48% haven't or didn't know. So that I think that this makes this very timely. We're going to examine in this webinar gender-based violence in the context of COVID-19 approaches, and specifically what can we do in relation to communication and community engagement. And we have a great panel with a lot of experience directly from the field and from WHO and UNICEF. So without more ado, I should have introduced myself. Apologies. I lead the work on violence against women. I've led the work on violence against women and GBV for many years in WHO. I'm going to hand over to Saba Sarif, who is our GBV and Emergencies Technical Officer here in HQ, to kick us off with just an overview, and then we'll move to some country experiences. So over to you, Saba.
Thank you. So my presentation will offer an overview of violence against women in the context of the COVID-19 pandemic and explore key considerations for risk communication and community engagement response based on existing global guidance. Next slide, please. Thank you. Violence against women, particularly intimate partner violence and sexual violence, is a major public health issue. Globally, 1 in 3 women experience physical or sexual violence in their lifetime, most often by an intimate partner. This is a stark reminder of the scale of gender inequality and discrimination against women preceding the COVID-19 pandemic, and it challenges us to critically consider the added vulnerability that emergencies, including outbreaks, introduce to the safety and security of marginalized groups. Women who are displaced, refugees, and living in conflict-affected areas are particularly vulnerable. Disruption of services, broken social and protective networks, and cultural factors increase risk of violence and may exclude women from decision-making spaces and restrict their access to information and life-saving services. Combined with other vulnerabilities, the risk of violence is even further compounded. The elderly, children, or persons with disabilities, for example, have special needs and limited opportunities to cope and adapt to public health emergencies like COVID-19. The health impacts of violence on women and their children are significant, which makes this an issue that we absolutely cannot ignore. Some of the health consequences of violence against women include serious physical, mental, and sexual and reproductive health problems. Specific examples include sexually transmitted infections, HIV, unplanned pregnancies, depression, post-traumatic stress, and others. Next slide, please. Public health and social measures to curb the spread of COVID-19 have exacerbated the risk of violence against women. Since the onset of the pandemic, over 188 countries have imposed countrywide closures. A UNFPA impact brief released in April projected an additional 31 million gender-based violence cases globally in the first 6 months of the COVID-19 pandemic. An additional 15 million cases of gender-based violence are expected for every 3 months that lockdowns continue. Increases in violence can owe to a number of factors. These include reduced access to necessities, financial stress, the potential breakdown of societal infrastructure, quarantines and social isolation, financial stress, and other issues like family separation in crisis settings, or the inability to escape abusive partners at home. Women comprise 70% of the global health workforce and may further confront risk of stigmatization, discrimination, and violence as essential workers and those suspected to be carriers of COVID-19. Disruption of essential services during the pandemic also compromised the care and support that GBV survivors need, like clinical management of rape and mental health and psychosocial support. This also can fuel impunity for the perpetrators. With these considerations in mind, it becomes essential that risk communication and community engagement strategies for COVID-19 address GBV as a major public health problem, and every single actor has a role to play. Governments and policymakers must ensure that social welfare and sexual and reproductive health services to address violence against women are included in national COVID-19 response plans. In March of this year, WHO released operational guidance that specifies essential services to maintain during a COVID-19 outbreak, including clinical management of rape and intimate partner violence. Following the presentation, I'll share that resource link with you in the chat. Health facilities should identify and provide information about services available locally for survivors and establish referral linkages with other sectors. That can include legal support, social services, or safe shelters for survivors of gender-based violence. Job aids, messaging, and updated referral information should be developed for service providers in addition to targeting key communities with service information. Health providers are often the first point of contact for survivors and a key entry point for referral. As such, they need to be aware of the risks and health consequences of violence against women. They can also play an important part in educating patients and the broader community about violence against women and the associated health risks under the COVID-19 accommodations for health response. Next slide, please. Humanitarian response actors specifically have a responsibility to ensure that gender-based violence risk mitigation measures are being integrated into their sectoral plans for COVID-19, of course. And there's further a responsibility to inform communities about safeguarding measures and mechanisms for reporting incidents of sexual exploitation and abuse in a manner that is language and culturally appropriate for the beneficiaries that they serve. Key messages for community members should address the increased risk of violence against women during the pandemic, the importance of staying connected with people of trust, and messages and service information that can be shared to support someone who is experiencing abuse. Women must also meaningfully be engaged in risk communication and community engagement actions as primary caregivers to children, the elderly, and the ill. The important role that women have in communities must be recognized, and it is critical that they're engaged accordingly in risk communication and community engagement approaches. Next slide, please. Finally, I'd like to present you with some resources for further action, which specifically integrate considerations related to GBV in respect to risk communication and community engagement strategies. What I have presented here in the far left-hand corner of your screen are some infographics that have been developed by WHO, which are appropriate for social media or print media for large-scale campaigns and offer critical messages for a variety of actors that should be engaged in integrating gender-based violence into the COVID-19 response. There are also some regional tools that have been developed by the Regional Risk Communication and Community Engagement Working Group, which looks specifically at marginalized groups, including GBV survivors. There are tools that are specific to the Eastern Mediterranean, the Asia Pacific, and I've also offered you a web link here for a website created for the West and Central Africa. There's also a piece of guidance that has been developed to address the role of community-based healthcare in the context of the COVID-19 pandemic, which is a joint product developed by WHO, UNICEF, and the IFRC. And there's plenty of context related to how messaging can be formulated to address violence across the life course for various groups that are vulnerable or at heightened risk. Finally, for humanitarian actors, there's an addendum or supplement which has been created for the IASC guidelines for integrating gender-based violence into humanitarian action, which is specific to COVID-19 and offers a unique chapter related to how to integrate GBV into risk communication for professionals in RCCE. Thank you very much.
Thank you, Sava, and thank you very much for keeping to the time. We are going to move straight away to our colleagues from Iraq, and it gives me great pleasure to introduce Dr. Kamal O'Leary, who is the Health Cluster Coordinator, and Dr. Rana Mohammed, who is managing the GBV portfolio. And after these two presentations, we will have a little space for some questions and answers before we move to the next round of presenters. So over to you, Kamal and Rana.
Hello, do you hear me?
Yes, we can hear you.
So thank you very much. So I am as they mentioned, I am the health cluster coordinator for Iraq. And we'll be giving you as a short presentation on the health cluster as such. And so I'm sorry, I think we seem to have some kind of a connection. Please, one more, if you can confirm that you can hear me, if that's okay.
We can hear you.
Yes, I'm very sorry. We seem to have some connection issues. So again, thank you very much. I am the health cluster coordinator for Iraq, and we will try as much as possible to give you a brief information on the health cluster and how we use of mass media campaigns for GBV risk communication, particularly under the COVID-19. I will give you the broader overview, and then my colleague, Dr. Rana, will go more into detail on the WHO response. Next slide, please. Okay, so this is just a picture of the humanitarian cluster approach. As you can see, there are a number of clusters. We did not ask them for health to be put on top, but so it is. So you have such clusters as health, logistics, food security, emergency livelihoods, nutrition, other clusters. And here also in this picture, it shows you the cluster itself and the cluster lead agency. So put in a nutshell, a cluster is a group of agencies that works to perform one particular emergency response in one sector. So in our case, it is health. It is the cluster lead agency is WHO, and the cluster comprises partners who are NGOs, whether they be local or international NGOs, the government counterparts, and the sometimes the donors as well, who are part of the cluster members. Now it's based, the whole cluster approach is based on the principles of partnership. These are equality, meaning that all the partners should have an equal voice and an equal say in the response. Transparency, in the sense that we need to be open as to our response. We need to hear also from the people who are going to benefit from this response so that it can help us to plan. The next one is results-oriented approach. So of course, in many of the cases, we, agencies or institutions tend to be very much focused on process, but in a humanitarian emergency, we need to keep focus on the result. So that is one of the approaches. The next thing is responsibility. We as clusters or as humanitarian agencies are accountable and responsible to perform and to ease the humanitarian consequences of any crisis. And complementarity means as a cluster, as being different partners, each one needs to complement the other and thereby ensure an adequate response. Next slide, please. So this is a picture of how the health cluster, a formally activated health cluster in the humanitarian framework. So you have the United Nations Under-Secretary General for the Humanitarian Affairs, who is also the Emergency Relief Coordinator. They sit in New York. Then within the country, you can see these are all these bubbles that are showing are all the structures that are within the country. It begins with the Humanitarian Coordinator, who is reports, and their reporting line is to the government, which is the National Disaster Management, and ultimately the National Health Authorities. The humanitarian coordinator also feeds back to the humanitarian country team, which is also led by the humanitarian coordinator, who is known as the HC. Now, we will not go into too much detail. OCHA is here. That is actually the Office for the Coordination of Humanitarian Affairs that coordinates the entire affairs of all the humanitarian actors. Coming down to your bottom left is the health cluster team at the national level and the subnational level. So the cluster coordination team and the partners, we liaise and coordinate with the national health authorities. As you can see, it is collaboration, liaison, and information sharing. We are also reporting we are accountable to the cluster lead agency, which is in our case WHO. And there is also what is known as the inter-cluster coordination or working group made out of other clusters. There is rapport and liaison with them and coordination, as well as individual clusters which are specific to us. Like, for example, in case of cholera epidemic, we need to liaise more with WASH. In case of malnutrition, we need to liaise with nutrition cluster where it exists, or with food security, etc. Next slide, please. So bearing that picture in mind, this is the structure of the Iraq Health Cluster, the coordination structure that we have. So we have a national health cluster that is, the presence is in Baghdad and in Erbil, equally present. Of course, we have more presence in Erbil at this point, because that is where we have more of the partners. In addition to, okay, I think I can see in the chat that you would like to see me, so I will let you see me as well. Here I am. And the national cluster, of course, we have 7 subnational clusters, as you can see, that are in the different governorates that were affected by the conflict. So the subnational clusters, they feed back information to us. We also liaise with the WASH and food security, CCCM, shelter and FI cluster, other clusters as well on a national level. We provide feedback to the returns working group. We are a member of the returns working group. We're also, of course, member of the intercluster coordination group, what is known as the ICCG, and the access working group, as well as the IIC call center. Now, why am I actually trying to give you this entire picture is because the IIC, the call center, is one of the channels, apart from the access, apart from the CWC, which is communication with communities. So these 2 channels are part of the vehicle that we use also to communicate the GBV messaging. Now, under the health cluster, we have 4 working groups: physical rehabilitation, nutrition, mental health and psychosocial support, and reproductive health. Now, under the MHPSS, mental health psychosocial support, we are actually, WHO is leading this working group, but there is also a presence from the protection cluster side, which is intersource, because this is now a cross-cutting area of intervention, which is mental health, and under which also comes the GBV interventions. So this is the structure at the present moment. Of course, we had to update this infographic several times. So this is the way it stands at the moment. Next slide, please. So I will just let you know that we had developed, along with support from, of course, the regional office, the Eastern Mediterranean Regional Office, what we know as EMRO. The regional office, our technical GBV technical officers support after the mission to Iraq in January 2019, there was a discussion that we need to, mainstream GBV more in the health cluster response, as well as make sure that messaging is going out in an adequate manner. So we came up with this idea that we develop a document that is an advocacy messages on GBV that should go out through the health cluster. So the document basically focuses on these 3 key messages, which is GBV is a significant threat to public health and emergencies. The other one is mental health of GBV survivors. And the third one is child marriage. So now I'm not saying that these sub bullet points are all the key messages that have been, that are in the document. You will find the document linked in this presentation towards the end of the presentation. However, some of the points that we came up with are, for example, health services for GBV survivors remain inadequate in humanitarian settings. This is something that is has been identified. In addition to the fact that health facilities should also be empowered to be able to provide GBV services to potential survivors, to people who are suspected of having suffered violence. So this is something that, Sabah they have also put it in the beginning of the presentation. The health worker is the first point of contact for most of the survivors. So we want to make sure that these healthcare providers are trained and are able to notice when a person is a potential GBV survivor. So now the other thing is that health cluster should also ensure that GBV is prioritized in emergencies. That was the main reason why we actually took this thing forward. It is a pilot project that we did in Iraq, and we also shared our experiences later on in 2019 with other countries when we had a regional meeting. And so this document was also shared, and I I think other countries are also working on developing such kind of advocacy messages. Now, regarding mental health, so all the health workers should be able to provide first line support. So this is PFA, which is known as psychosocial first aid. That is also something that we are working on. So we actually, what we did was we put out these messages there, and based on that, we are, trying to work on our humanitarian response plan and also incorporate it into our activities on a day-to-day basis. I'll not go into further details on this mental health, but you can read it, of course. The child marriage, of course, it is an issue that is quite unfortunately widespread also in our part of the world. So women and girls need to be empowered to access health services, and these services should cater to their needs and should be safe and provide them the environment that they require. So I think with that, you can of course go further into these into the advocacy messages. The link is in the end of the presentation. And with that, I will hand over to my colleague, Dr. Rana, to take it forward. Thank you.
Thank you, Kamal. And I'm going to ask you, Rana, to keep it as tight as you can, so that, because we're already over time for this.
Yes.
Thank you but just so before, sorry, Dr. Rana, just before you start, I want to just after Dr. Rana's presentation, we'll go into a question and answer time. So if you do have questions, please input them into the Q&A function on Zoom. That's where we're going to get your questions. We're not going to go to you if you raise your hand. So please input your questions there. Thank you. And it would be for Dr. Rana, Dr. Kamal, and Saba as well. Thank you. Dr. Rana, go ahead.
Yeah, thank you so much. Well, I will try to make it as short as I can. Well, as we all know that Iraq, like any other place, affected a lot with the COVID-19, the isolation, the restriction of movement, it all decreased the accessibility of the GBV services. So in this way, the healthcare providers in the emergency unit became the first and sometimes the only entrance for the GBV cases. For this, we would, in coordination with the GBV subcluster, WHO, EMRO, and the Iraqi health cluster developed something like guides, very easy to use, remote and in-person counseling by healthcare providers. This document contains a guide or a flowchart which guides the healthcare providers how to deal with suspected cases that may subjected to any kind of violence or abuse during their dealing with her health condition. Also, this document contains a list of updated referral pathway guides to healthcare and other GBV services in Iraq, and contains tips for coping with stress at home. Also, put in mind the importance of following the COVID-19 protocols to decrease or to restrict the spread of COVID-19 during the dealing with the GBV cases in face-to-face way in the clinic. Next slide, please. Well, in Iraq, we have no community outreach services in the Iraqi health system, and the community GBV units facilitate the GBV services with the coordination with the NGO partners. So to overcome this condition, WHO focused on integrating GBV services into the health services and mental health services available in the PHCs. Also, we prepared consolidated key messages on GBV prevention and MHPSS jointly by WHO Health Cluster through the National MHPSS Technical Working Group and the GBV subcluster. This message should be used in dissemination campaign on social media through SMS, TV, and radio channel. And we also focused on the good linkage of survivor with the needed GBV services. So WHO, in coordination with UNOPS, we added the IIC call center or the hotline to the awarenesses raising product, which is produced by WHO, and translate it to the local language, the Arabic, the Kurdish, Sorani, Badini, and Kormanji. Next, please. A lot of challenges really faced us because of the curfew. The Women's Center was not available, and all the GBV supported mostly stopped, and this badly affected the survivor in finding the accessible services. And also, not all the healthcare providers and survivors are familiar with the online services. And in a community like Iraq, sometimes using the online services or the telephone for providing GBV services may even give put the survivor at risk of in certain community. And also the availability of proper internet connection and phone coverage were a big challenge facing providing this kind of services. Also, not all healthcare centers have or updated their referral pathway for GBV survivors, so mostly they cannot refer their cases. Next, last slide, I guess. Next, yeah. The important thing that during the curfew, only as I mentioned, the healthcare providers in the emergency unit were able to provide the services. So we have to focus on capacitating them beside the healthcare providers in the PHCs. The online services played, as you know, an important role in continuity of the GBV services. And as I mentioned, the integrated GBV services within the health and mental health services gave us a good result in decreasing the stigma and ensuring the availability of sustainable, of community-based services for all the vulnerable population, including the women. I guess this is all from my side. I'm sorry to talk a lot. We have the next slide contains the reference we used. It's important. Maybe Kamal, do you want to go through it?
Sure. Yes, please. Just for the references slide, so I can just explain why we included them, if you don't mind. Oh, it looks like it's not available.
Well, this comes up. We can maybe you can put them on the references on the chat. Thank you, Saba, for an overview, which I think highlighted two things. One is that violence against women was already here and very prevalent before COVID, and that many of the measures to address COVID may have exacerbated it some places, and at the same time, the same situation was limiting access to services. And in some way, this really highlights the importance of the community engagement and the communication with communities as a way to addressing some of these issues. And then thank you, Dr. Kamal and Dr. Ran. I think it's really great to see so much progress having been made in Iraq in terms of integrating GBV in the humanitarian response. I mean, as you saw from Kamal's presentation, the coordination mechanisms in humanitarian are complex. But I think this is also part of the, in all community engagement, we also need to be addressing all these different sectors and ensuring coherence of messages. So this applies also to non-humanitarian situations. And Dr. Rana, thank you for sharing some of the key approaches. There are several questions, many questions coming up. I'll start with a few, and we can do maybe 5 minutes of questions, and then we'll move on to other presenters, and we'll come back to the questions. One question was to Dr. Kamal. Can you speak to the process by which the key messages were identified, and you know, what kind of groundwork was done to make sure that these messages resonate with the target population? Then a question to any of the presenters: can you consider ways to empower women in social support activities, for example, through you know, offering food and utilities, and how this may contribute to reducing violence? And then one last question before we do a round, and then we can move on to others. There's a specific question for Rana. Well, just sharing another interesting success story from India about healthcare women workers in India, and dedicated radio programs. Another question around what is risk communication response in terms of stigma, GBV, and discrimination against healthcare providers on the front line. So let's start with those three, and then we can see how much time we have for more.
Right. Thank you very much. So yeah, regarding the groundwork on how we were able to identify these, you know, the issues that are facing and the key messages was basically our coordination with the GBV subcluster. So, you know, under the protection cluster, you have the GBV subcluster. We have been attempting as much as possible through our focal persons there at UNFPA, because the GBV subcluster is led by UNFPA. So the information that was actually coming from their side as well, in addition to our own missions that were conducted by our technical officers from the EMRO region, to identify alongside them what are the main gaps that we face, and based on those gaps, what are the mitigating measures that we need to be taking. So that was basically how it was done. And of course, there has been a lot of liaison between us and coordination between us and UNFPA and protection and information gathering over the past couple of years since the cluster approach has been instituted in Iraq in 2014. So that was basically the thing. In addition to, you know, assessments, needs assessments that were conducted by different partners. I hope that answers the question.
Sava, thank you for that. Sava and Rana, do you want to respond to any of the other questions? And maybe I'll throw in one more. I'm trying to there's lots of questions. Thank you very much to everyone. And we may not get through all of them, but we'll keep a tally of them and make sure you get a response later. One question about the role of helplines. There was the question about risk communication in terms of GBV stigma and discrimination against healthcare providers in the front line, which it might be an interesting one to address. And then the role of helplines. Does anyone want to take those two on?
Yes. So I'm not sure if I got the question right. If you can just correct me if I'm wrong, but the fact that, you know, stigma in the sense that health workers facing the stigma or the patients from accessing the services.
Sava, or I think it was a general question about what is the role of communication and community engagement to address issues of stigma and discrimination against frontline healthcare providers, which we've seen in several countries.
So yeah, it's basically, you know, the whole approach, and I think in general it is used in other countries as well, is that the more aware people are, the more they will be able to, you know, accept these services. Now, yes, there has always been issues of stigma, not just towards GBV, but also towards other issues, right? Currently, we're facing issues of stigma to COVID as well. So for the GBV issue, yes, it's difficult to actually, for that particular reason, it's hard to say that, okay, this health facility is specific to providing only GBV services. So that is the reason why we have to incorporate it within the existing health system as much as possible. And the survivors themselves, we are providing them with a GBV hotline, so they can reach to where they can get advice on then where they can go. So that in a sense, it kind of minimizes the stigma and the issue that in the society. But maybe I don't know, Rana, maybe you can take this a little further than I do. But from my perspective, I see that the more awareness is created and the more safe spaces and the more safe channels for the survivors to reach out, the lesser the stigma and the issues affect them. Over to you, Rana.
Yes,
Thank
exactly
you.
what Dr. Kamal said. And as I mentioned in my presentation, one of the good lessons we have was the integrated GBV services into health and mental health services. So whenever there is a suspicion that this lady has an issue or something like that, the healthcare providers themselves can deal with the case and can provide the services as much as they can, unless the lady need advanced services. And also in this way, the healthcare providers themselves should be aware about the referral pathway and how to direct the GBV cases or the survivor. I wish I managed to answer the question.
Thank you, Rana. Saba, do you want to add anything?
I have nothing further to add.
There was a question also about mandatory reporting, and I just want to say that a lot of countries have mandatory reporting of domestic violence, which has negative impacts in terms of it affects health-seeking behavior, because many women, particularly who may be seeking health care, may not necessarily want to follow, through a legal or criminal procedure, particularly against husbands or partners. I think this has come up repeatedly in many of our trainings in countries. And at the moment, the ICRC is initiating a policy review on this, and we are hoping to join them in coming up with some policy recommendations around this issue. But it is in many cases, in many countries, a law that puts health workers in difficult situation of having to balance the confidentiality and having, I think what we emphasize is that where there is a legal onus on health workers to report, it's important that women be informed of the limits of confidentiality so that they disclose in accordance to, with full knowledge of this. But it's a challenging issue. I won't say more about it, but thank you for the question. We are tight for time, so we're just going to carry on with our agenda, but we will have some more questions and answers, and there's many, as I said, that we haven't been able to address. But we're going to move now to Dr. Ini. Inigebe Oyinloye is her full name, but we better known for us as Dr. Ini, who will talk to us about the experience of engaging communities in northeastern Nigeria around this issue. So over to you, Dr. Ini.
Good afternoon, everyone from Nigeria. Thank you, Dr. Claudia. In the next few minutes, I'll be trying to talk, I'll try to be very fast as much as possible, and I'll be discussing on how in Nigeria we've been able to engage communities to strengthen the perception of health workers and their role in provision of care for GBV survivors during COVID-19. Just like our Dr. Claudia mentioned, my name is Dr. Inibe Oyinloye, and I'm the GBV focal point for the Northeast Nigeria. Next slide, please. So I'll be talking about it. I'll give a brief background, the situation analysis. Nigeria is actually made up of 6 geopolitical zones, which the Northeast is actually one of it. But however, the humanitarian response is focused on the Northeast. And this because there have been some crises which actually started in 2009, but the peak period of it was between 2014 to 2015. And so this crisis has actually led to massive displacement of people, of food. There've been insecurity. And out of the Northeast states that have been affected, the 3 major states that have really been affected are the best states. That's Borno, Adamawa, and Yobe. Approximately 6.9 people have been seen to be in need of humanitarian assistance. And out of this, about 5.3 million actually need health assistance. There are about 65 local governments that are covered in the best state, and the situation analysis shows that out of the 65 local governments, about 28 of them are actually extremely in need of humanitarian assistance, while 30 actually are classified as severe, and we actually have 2 local governments which is actually termed under the stressed local government. Next slide, please. In the midst of this crisis, there have been an increased incidence of gender-based violence. And just like I mentioned, with the peak period of it being between 2014 and 2015. Now, women and girls in particular have actually been the most vulnerable in all of this. There have been issues of abduction, there have been rape, there have been forced prostitution, and it's been estimated that about 700,000 female are actually in the IDP camps, and they're actually the major ones that are mostly vulnerable in the midst of the GBV crisis during the humanitarian response. So how has this, the impact of COVID-19, how does it come in? So we have seen that since the onset of this pandemic in 2020, it's been projected that the number of people that are in need of urgent assistance in the Northeast actually increased from 7.9 million to about 10.6 million. So you agree with me that COVID-19 is actually deepening the humanitarian needs, and this includes need for healthcare services, including timely access to health services for our GBV survivors. Next slide, please. So I'll be talking about the approaches we used in Nigeria to actually engage the community to ensure that the GBV response is actually strengthened. We started by engaging the community leaders and the officials, and we carried out some sensitization meetings with the major focus of sensitizing the community leaders, the traditional leaders, the IDP camp chairman, and other government officials, knowing that they're the gatekeepers in their communities. We also carried out stakeholders advocacy. The major aim here is to ensure we can strengthen our GBV referral linkages. Major people that were in the stakeholders meeting we had included those from the Ministry of Health, the primary agency, we had people from the Nigerian Police Force, Ministry of Justice, and we also ensured that the traditional leaders who are the gatekeepers at the community level were actually in the stakeholders advocacy meeting. Next slide, please. And so the traditional leaders during this meeting actually shared their concerns and also mentioned their challenges as regards gender-based violence. We gave an opportunity for each of them to let us know what are their expectations and what are the major challenges they face in the communities as regards GBV and even in the context of COVID-19. We also ensured in this meeting that the role of the health worker, which is to improve health services, was actually clarified by the WHO and also the Ministry of Health. So the meeting actually provided a platform for us to be able to inform the community leaders on what the role of the health sector is as regards gender-based violence in the background of COVID-19. The major key messages that we had in this community meeting, sensitization meeting and advocacy meeting were to educate them, the community leaders, that the health worker is not, does not blame the survivor. We also let the community leaders know that their major role is to ensure that the survivor receives a holistic care. They are not to make decisions on the survivor, and in cases where the survivor actually permits, the role of the health worker is to ensure that the survivor is referred to other services if the survivor actually permits for that. Next slide, please. Another avenue we actually used to engage the community was through the use of the hard-to-reach mobile teams. So in the midst of this humanitarian crisis, which actually started in 2009, like I said, and the peak period was between 2014 and 2015. So the WHO established the hard-to-reach mobile team with the major aim of scaling up emergency intervention, strengthen the health system, and also provide health services for these affected areas. We try to ensure that the health workers actually come from communities that they will be rendering the services. So the hard to reach actually links community to health services in over 70 local government areas. And these are mostly settlements that some cannot even be accessed. Some have been affected by the armed conflict. Some are actually in the IDP camps where we have internally displaced persons in areas that are having challenges in accessing quality of care. Next slide, please. So the hard to reach team is made up of 4 people. 4 health workers, which is usually a nurse and a midwife who leads the team. We have a community health extension worker, we have a JHU, and we also have a recorder. So the 4-man team is usually supervised by an LGF, making it 5-man team. Amongst other services that are offered by the hard to reach team includes they carry out medical consultation, focus antenatal care services. They provide health promotion, immunization, and they've been trained on gender-based violence, provision of first-line support with integrated with mental health and psychosocial support. They also provide nutrition and screening. They provide HIV screening, amongst other services they render, and they carry out their activities on a daily basis. So on every day of the week, they actually go into the settlements to ensure that sessions are conducted in these areas that cannot access healthcare. Next slide, please. The health worker in the hard to reach mobile team, like I mentioned, are the frontline service providers as regards gender-based violence. So in the midst of, during the pandemic, they have been trained on COVID-19 IPC guidelines. So the COVID-19 messages have been integrated into their routine activities. So they provide GBV services with COVID-19 sensitization and awareness at the community level. So daily they go out for their sessions and they conduct this health session. They increase awareness and sensitization on key messages as regards gender-based violence as well as COVID-19. Next slide, please. Next slide, please.
Dr. Eni, are you seeing the next slide? We are seeing the next slide.
Okay, that's fine. I've gotten it now. I've seen it now.
Okay.
Thank you. Okay, so prior to the COVID-19 pandemic, the hard to reach, they go about their normal sessions, like I mentioned. They ensure sensitization on key household practices. But with COVID-19 integrated messages, they carry out prevention, and they also ensure that they use pictorial to also educate the communities. They also engage the community leaders as agents of change. Okay, in the northeastern Nigeria, I recognize that community leaders are not only decision makers, but are actually highly respected, and the community carries out what they see their community leaders do. So the hard to reach mobile team have continued to work closely with the communities. So they model the hand washing, social distancing, use of face masks during their health education session in the community, using the community leaders as a model for change. Next slide, please. Looks like it's a bit slow at my end. Sorry for that.
We are seeing the next
I
slide,
know
so
the next.
maybe you can carry on.
Okay, so I'm just like I mentioned, using community leaders as agents of change. The next slide actually shows us the Sheon of Borno. He was actually used as a key model for hand washing. So he demonstrated hand washing in the community, and the communities have, embraced this, seeing that their key leader is actually being used as a model for change. Next slide, please. Next slide, please. Okay, we've also used information and education and communication materials as the IEC materials. So WHO developed some IEC materials with key messages focusing on the role of the health worker as regards prevention of gender-based violence. So we produced it in English, and we also translated it into other languages. This is to ensure that the community can easily accept it. So the IEC materials are not only used for campaigns and advocacy, but we also use it during 16 days of activism against the gender-based violence. The major aim is to engage the community and also increase the awareness on gender-based violence and its impact on the society. Next slide, please. So what have been the lessons that we have learned in the Northeast Nigeria? We have realized and learned that integration of gender-based violence and COVID-19 sensitization into the WHO Hard to Reach program has been effective in increasing service awareness and utilization. We also learned that it's critical to identify cultural barriers and norms. For example, in the Northeast, it's actually a taboo for women to speak in the presence of men. So you will have to engage the women separately and engage the men separately. And also, as regards some issues of intimate partner violence, it's a taboo for them to speak up freely about intimate partner violence. So we have learned that it's critical to identify the cultural barriers. We also learned that using the community leaders to convey health behavior messages actually strengthens the community acceptance and compliance. That's because they see their leaders do it, and these are the decision makers. Finally, we realized that interpreting the IEC materials into local languages has actually increased community engagement in gender-based violence and COVID-19 prevention at the community level. Next slide, please. And thank you very much for listening. These are the references that we actually used for this presentation. Thank you, and over to you, Dr. Claudia.
Thank you, Dr. Rini, for bringing out those lessons learned, the importance of translation to local languages and understanding cultural barriers. Also, you addressed one of the questions that we didn't get to around the role of faith leaders and community leaders. So thank you for that, and the mobile clinics. We'll move straight over to Caroline, who will talk to us about Cox's Bazar. We're running a little bit tight on our timeline. So please, Caroline, go ahead, and then we'll have a little break with questions and answers before we turn to our colleague from UNICEF. So over to you.
Thank you so much. Hello, everyone. This is Dr. Caroline speaking from Cox's Bazar IOM Rohingya Refugee Response. I'll start off by giving a slight background to the Rohingya refugee response. In Myanmar, in 2017, there was a mass exodus of people who are the Rohingya people from Myanmar to Bangladesh across the border. This was triggered by the systemic discrimination and targeted violence against these people in Myanmar. So over 850,000 Rohingya people crossed the border into Bangladesh, and they were settled in 34 camps over in 2 sub-districts of Cox's Bazar. 52% of these people were women and children, and these were supported by the government of Bangladesh with support from the United Nations, NGOs, and other civil society and donors group. With regards to the COVID, next slide, please. Yeah, with regards to the COVID, impact of COVID in Cox's Bazar refugee response, as of the report by WHO on 4th of November, we had over 52,000 tests done, of which 5,000 were positive for COVID. And of these, only 339 were positive among the Rohingya camps. This is relatively lower, less than the number that was anticipated at the beginning of the pandemic, as it had been calculated to, it will be about 1,500 within the camp. However, even with these small numbers, next slide, please. Even with these small numbers, the COVID pandemic had a great impact on the health response and the refugee response generally. Next slide, please. There was a fear for a reduction in the health-seeking behavior by the Rohingyas for health services, as evidenced by the decrease in all health services consultations within the health facilities. On the right is the snapshot of the IOM health services database. We can see the decreasing trend for all health services within the response. As a result of that, because the Rohingyas were not coming to the health facilities, IOM established what we call the health outreach teams. These were established to go out into the communities to support, ensure that they deliver services to the people in the communities. They worked in collaboration with the community health workers who are existing and volunteers. And these were from all the different sectors, like MHPSS and protection and GBV. And they were to ensure that to enhance the ongoing and planned activities for COVID-19 in the community-based surveillance. They were also to ensure that they provide risk communication and community engagement. They were also supposed to provide home-based care for COVID-19 patients that did not like to be admitted in facility-based isolation. And also they were supposed to help strengthen continuity of other essential health services through community outreach and referral. The teams, next slide please. The teams were composed of a medical officer, a medical doctor, a midwife for all the SRH activities, a nurse, a medical assistant, and as I mentioned, the community health workers, and they were providing all health services as the need required, and risk communication to the group. So these, all our staff were trained in GBV and clinical management of REP for all our health staff were provided. We were trained in that. And so they were able to reach out and provide, in addition to all their services, GBV specific messaging and services within the community. Next slide, please. Slide, please. So IOM has specific linkages between the GBV and health, which have been developed with time. And these are kind of very strong for us. All health facilities in our camp, in our response, are well equipped and have trained personnel to provide clinical management of REP for GBV survivors, as well as have the respective referral pathways between GBV and health and all other necessary services for the GBV survivors. In addition, in all the isolation and treatment centers that IOM established within the response, the same thing was done. It was well equipped, and all the clinical workers were trained on provision of GBV and on provision of clinical management of REP, and were equipped also to provide clinical management of REP. So all the ITCs had sections for a maternity wing where all SRH, GBV, and maternity services were provided. This is because, of course, as most of the presenters have mentioned, that there is a disproportionate impact on women and girls by the COVID response. So we had to take this into account, and all the ITCs that were established were responsive to GBV management, and as well as segregated for gender with different rooms, wards, all segregated by gender, and the washrooms and all the privacy was maintained for different genders. So this helped us very much in dealing with GBV survivors that were referred to the health ITCs in the treatment centers, as well as in the different IOM clinics. The approaches that we used, next slide, please. The approaches that were used by the health teams, the health outreach teams, were mostly household visits, interpersonal communication sessions. They engaged, like Nigeria, the community leaders, religious leaders within the camps, and all the teams were equipped to be able to navigate through the camps, maybe by the different transportation means, like the CNG or a bicycle, as you have seen in the picture in the first slide. And we supported radio programming with integrated messages of GBV and health, as well as producing IEC materials where the key messages also integrated GBV and health. The next slide shows an example of some of the IEC materials that we developed and distributed. The IEC materials were very simple. They were translated both in English and the local language that is clearly understood by the community. And they were very, they had pictures, simple pictures to demonstrate what was being discussed. And of course, they had a lot of GBV messages integrated within them. So this also helped pass on the integrated messages in the different community and help with the risk communication in the community. So based on that, we had a lot of facilitating factors that helped us to deal with, to have a good risk communication and community engagement strategy, which was, of course, a strong and cohesive risk communication coordination at all levels of IOM, from global, regional, and local levels, as well as IOM participating in the local risk communication and community engagement coordination platforms, like the working groups, the health sector, the GBV working group, and the SRH working group. So all these were done in an intersectoral manner, and all key messages out of these discussions we integrated the messages of GBV and health. IOM as an agency is a multi-sectoral, intersectoral agency, and therefore at agency level, we easily collaborate and deal and produce intersectoral messages as the need arises, especially for GBV and health. We developed and dispersed very simple job aids, which were easy to understand, and resource materials, and they were translated into the local languages for the community to easily understand them. Of course, engaging the local community and the key opinion members of the community was very facilitating for our work. As Nigeria mentioned, they are respected and their opinion to the community really is regarded highly. We had, of course, sometimes to engage translators as we did our work because of language barrier, and this also helped to simplify the work that we did. So this, there were also many challenges as we did our work, like language barrier that I mentioned. Many times they speak different, the service providers and the community speak different languages. So we needed the use of translators. Then we had less acceptance for care workers at the community level. So we had to lobby and advocate rapport to build the rapport between the community and the health workers. This helped them to be accepted better. So there were the camps in Cox's Bazar are highly crowded. So ensuring social distancing was very challenging for us. For a very long time, the government of Bangladesh restricted communication and connection within. So this, of course, challenged the remote communication channels that will be that would have helped us with social media campaigns or any other alternative communication channels that for communicating to the community. And of course, the guidelines, the COVID guidelines that restricted the number of the movements and number of people that can converge also limited our staffing levels within the community and the services, therefore the services that we could provide at the same time. So
Caroline, sorry to interrupt, but can you please wind down so that we can move to our last speaker because we are running out of time. Thank you and sorry.
That actually we've come to the end with the last slide where we had a lot of benefits for engaging in risk communication and community engagement, which was very fruitful for us. So thank you. Any questions? Welcome.
Thank you, Caroline, for the experience, sharing the experience of Cox's Bazar and talking also about the multi-sectoral response, which was another of the questions we hadn't gotten to. So I think we are answering questions as we move along. I'll move now to our last speaker, who's Eric Santer from the GBV specialists in the emergency team and UNICEF HQ, you know, to share some of UNICEF's experiences. And then we'll have a final session on questions and answers. Eric, over to you. And I'll ask you to stick to the 10 minutes, please.
Thank you. I don't know if you can hear me.
Yes, we can hear you.
All right, thank you so much. And hello, colleagues. Just building up on the work that has been done by colleagues, WHO and partners in terms of how do we address GBV in COVID, particularly looking at risk communication and community engagement. So my presentation, I will basically be sharing with you what UNICEF is doing to complement these efforts and some recommendations in terms of how we can make this effective. Please move the next slide. So just to give you a background that like WHO and partners, addressing GBV in emergency is very cool for UNICEF. And this is something that the agency has in mandate in terms of making sure that GBV is addressed in every emergencies. As we know from the presentation of the overview of GBV from Sabah, in every emergency, GBV is escalated and COVID-19 is no exception. So even before COVID, this is something that UNICEF has taken very seriously. So it is part of our institutional commitments in terms of our strategic plan, in terms of our gender action plan, in terms of the full commitment for children and ability to the affected population, including protection from sexual exploitation and abuse. These are the areas that we focus on GBV, addressing GBV in emergencies. We're also looking at the safer and more effective programming in terms of the different sectors that we support to make sure that they contribute to better outcomes. So if it is health, if it is nutrition, if it is what, how do we mitigate GBV risks in those sectors to achieve better outcomes? We're also looking at building longer-term capacity and systems in terms of system strengthening. But also from the Oslo conference that was held in 2018, sorry for 2019, it's in 2018, the executive director made a renewed commitment for the agency to make sure that GBV is considered seriously. And then UNICEF is also part of the global call to action in terms of making sure that GBV is addressing all emergencies. Next slide, please. So this was already mentioned by Sabah, so I will not definitely go over this, but just to let you know that in every emergency, there are always GBV-specific risks related to that women and girls face. And that even in terms of our ROCCE efforts, in terms of women and girls not having access to information, not having access to services, being excluded from decision-making processes, not having access to community feedback mechanism. And this is likely due to their increased workload at home and other responsibilities that they have to meet. Thank you. Next slide. So for UNICEF, what we have actually been doing to support some of these efforts that WHO and colleagues are already doing, from the beginning of the COVID, we were able to support development of different guidance in terms of helping our country offices to make sure that GBV is integrated. And one of that initial approach was to make sure that GBV risk mitigation was part of all COVID response plans. So we have over 130 countries submitting response plan to address COVID, and GBV risk mitigation was included as part of that. And then we had a global webinar on GBV and RCCE because we knew that risk communication and community engagement was very critical. So we felt that it was important to have this webinar with all of our country offices, with our partners, to make sure that we are on the same page in terms of what the risks are and how we integrate GBV risk mitigation in that effort. And currently we have a partnership with SDD. SDD is a Social Development Direct. It's a firm that is responsible for capacity building. So we currently have a partnership with them to do training on GBV for all of our partners around the world. And that partnership includes community engagement on GBV through strategic communication and messaging. So this is also something we are looking at. How do we make sure that GBV is integrated into this process? And training of UNICEF personnel and partner responding to COVID-19 on GBV risk mitigation and GBV referral is something that we are also doing. And in fact, this is an indicator in all of our COVID response plans. We have this indicator to make sure that all countries are training their staff and partners on GBV risk mitigation and referrals. And I think they need to ensure that referrals are really considered, came out from the previous presenters. And this is very critical, particularly in locations where we have services and locations where we do not have services. So we may be responding to COVID in a particular location where there are no GBV services. So we want all of our frontline workers to know what to do. So probably if you are in health or in another sector, you don't say, oh, this is not my responsibility, like Saba mentioned from the initial stage, that addressing GBV is everybody's responsibility. Of course, we will look at what are the those responsibilities in terms of what we can do and what we cannot do. And then we were also, like others mentioned, able to support the development of GBV core community messages and information materials like the EPI we develop in collaboration with WHO and the other colleagues. But of course, with the GBV core messages, I think it's very important, particularly for women and girls, for community members, for service providers, in terms of how do they support survivors of GBV during COVID. And then the other point we have been supporting globally is the integration of GBV in RCC in all countries that are responding to COVID. This is part of our global HRP indicator, as well as our internal response, making sure that every country responding to COVID has GBV integrated into this process. And that also goes with the training of all frontline workers. Next slide, please. So in terms of what are some of the lessons learned in terms of the collaboration between GBV and RCC efforts in terms of effective collaboration, I think this came up already. We should be striving to be adapting GBV referral pathways to make them more easily understandable for affected communities. Prior to COVID, we probably had GBV referrals in some of the contexts. Now with COVID, situation has changed. So making sure that we are adapting referral pathways to make them more easily understandable for affected communities is important. And this is something that we found as a best practice, working with the GBV partners, making sure that you map the services. Even if you have done the mapping initially, services are shifted, different processes have been put in place, making sure that the GBV referral pathways are updated based on service mapping is important. And working together to understand and address barriers to services. I think this also came out in one of the questions in terms of how do we address barriers to services for women and girls. So we are currently using what we call the AAAQ framework, which is a framework that was adopted from the health development programs in terms of availability of services accessibility of services, acceptability of services, and the rest. I know we have jump over, but you can read the rest in terms of what that collaboration is. And in terms of essential food practices in communication, making sure that messages are context specific. So we are not taking messages from South Sudan to take them to Bangladesh, or taking messages from Nigeria to take them to Iraq. So you have to do that based on the context, making them very simple in terms of making them simple and using various communication channels. And what is important is engaging women and girls to help identify what their needs are. So I think this came out also as in terms of the groundwork, making sure that when we are developing these messages, we are engaging women, we are consulting women and girls to design these messages and also come out how do we disseminate these messages. And then engaging men and boys is also important, not at the expense of women and girls, but making sure that they are part of the decision-making processes as part of agents of change. And then involving gatekeepers and influencers, people we think that will be able to influence these messages, and then establishing monitoring and evaluation and learning system in terms of feedback mechanism to ensure that we are improving on what we are doing. Next slide. So there are some key things that we really want maybe for this presentation in terms of as we do this work to make sure that there are do's and don'ts that we need to keep in mind. In terms of make the safety and well-being of all women, that should be our priority. So whenever we are developing or disseminating these messages, we have to make sure that priority of women and girls is paramount for us, and also service provider, recognizing that gender inequality and discrimination cause GBV. So this is something we have to be mindful about, so that we are not actually contributing to that. Be alert of unintended consequences. Sometimes our intervention may have unintended consequences. We need to be careful about those. And then in terms of coordinating with the local services, and then you can read the rest of the slide involving men, like I mentioned, never use messages that exploit or stigmatize or stereotype. Even when we are developing messages, we have to make sure that these messages are culturally appropriate, and then creating messages that reflect on positive role models and interactions and behaviors. And then this should be an ongoing effort. So one-time awareness raising of messages is not the end. So it has to be ongoing activity. It's not a one-off campaign. Next slide. So again, in terms of what we need to do, I think this we have 10 million question and answers. In as much as we all have responsibilities to be part of this process, there are do's and don'ts in terms of what we should do. First of all, ensure that all frontline workers are equipped to facilitate referrals for GBV services as needed. So frontline workers should be trained when they receive cases, when cases are disclosed to them, they know where to refer. Speak to GBV specialists or service provider about general issues in the community. Probably doing health or other intervention may not make us GBV specialists, so there may be questions that may come up. So it is always important to consult with GBV specialists, collaborate with GBV specialists to consult women and girls. So in our consultation with women and girls, in our assessment, consult with GBV specialists to see what some questions that probably we can include to make sure that we identify these of women and girls. Ensure GBV response services are in place before raising awareness on prevention. So this is something because there were a lot of conversation around doing prevention. It's important to do awareness on GBV, what is sexual violence, but it is also important to make sure that we have response services in place before we do this. And then we have to make sure that we combine multiple sources of information. And then we should not try to identify GBV cases doing community awareness research. So I think this came out in terms of reporting. Survivors should come forward to seek services. What we need to do is to provide information about services that are available so that they should come to seek these services. So it's not, we should not be going out finding out if there are survivors, asking if there are survivors to document them. We should never seek survivors and then or ask communities to share detailed information about GBV incident, what happened, who is the survivor. So these are some of the things that we can do. So you can read again in terms of what the do's and the don'ts are. That will be very important in terms of service programming that we do. Thank you so much. If there are questions, then I'll be available. I know this was very fast, but yeah, we will be able to respond to questions. Thank you.
Thank you, Eric, and thank you to all the panelists. There's an incredible amount of information, lessons learned, and good recommendations. There have been questions about sharing the presentations, and we will make sure to do that. We are running out of time, but if people can hang on for another 5 minutes, I'll just take one round of questions for the panelists. If you can indulge, and it's fantastic to see that we still have 175 people online, and I'm sure others are looking through YouTube, and it's the range of countries is very impressive. So one question, to Caroline or Dr. Ini, how do we support the protection of the health team? And how do we use forums on preventive messaging at the community level? Do we keep women and men separately, or do we address it together? I'll start with those two, and then if we have time, we'll take another. Who wants to take that?
Thank you. Okay. Thank you, Dr. Claudia, and thank you for the question. So for our context in Nigeria, usually because the women are not allowed to speak where the men are, so we engage them separately. So usually in a typical session, we have the women sit at a space that is usually provided by the traditional leaders, wife, or the women leader. So we address them separately. But before we address the women, we have to address the men first and foremost to show the respect because of our context and our culture. Thank you, and over to you. I hope I've managed to answer the question.
Yes, thank you. Any of the other panelists want to respond to that? There was also a question about how to ensure confidentiality. And then the other question about how do we protect and also provide psychological support to the actual response team. If anybody wants to say something on that.
I think I can say something. For our case, as I mentioned, all the health workers that really go out into the community have been trained and sensitized about how to handle these cases. So when they identify them, because of the training they had prior to engaging with the communities, they really try to manage them appropriately. They will address the survivors or the people separately, women and men, and they will also know the referral pathways, how to refer, where to refer, and who and which services they will refer them to. In addition, we have MHPSS as part of the team to provide the psychosocial management wherever it is needed. Thank you.
Thank you. Eric, do you want to add anything or?
Yes, I think it's fine. Probably one thing to add is in terms of this training, one-time training should not be something that we should rely on, because there is always going to be staff turnover, new staff joining. So this reminder in terms of what the guiding principles are is very important to make sure that our frontline workers are really on top of the situation. Thank you.
Thank you. So I'm going to close the session now because we have gone a little bit over time, but it is clearly there is a lot to discuss and there's a lot of very good lessons learned and valuable experiences to share. I think that, communication and community engagement is really critical to, and especially we've seen in the context of lockdown, how important it was for people to be informed about what services were still functioning, where they could access help. And I think we need to continue to learn from each other. I really liked the do's and don'ts that Eric presented at the end. We need to engage communities, but we've also seen situations where, community health workers, for example, are put into unsafe situations because they asked to identify cases and, but that was clearly flagged as a don't. But at the same time, this link with services, having the information to know, for example, that post-rape care, it really is critical, within 72 hours for certain things like prevention of pregnancy, so there's certain engagement. I think another important point that was made is that we shouldn't start to do a lot of advocacy without having an ability to support and provide a minimum level of services. There were too many good things and good points made for me to try to summarize, but we'll definitely take note of the questions and try to come to them. There was some important question about children affected by violence. There is an information sheet that was produced by WHO looking at children, older people, and women in the context of family violence, which you can look at. But and there's guidelines also for responding to abuse amongst children and adolescents that you can look at. But there was questions about psychological support to health workers. So lots of things that we didn't have the time to get into. But we'll do our best to at least, put together some short responses to some of these points, and really, really appreciate that so many people are still online. And as I say, we have India, Bangladesh, Indonesia, Grenada, Sarajevo. I mean, we have really, really all continents and countries represented. So it's really exciting. And we really hope to continue this dialogue between the GBV folks and the RCCE folks. Thank you, and I'll hand over to Mindy.
Great, thanks so much, Claudia, and thank you for the presenters today. This was a nice, good, solid overview of the issues in gender-based violence, and it will really help those of us that are working in the response side for community engagement and communications to make sure that these processes, these methodologies get really utilized by those of us in the field. So thank you so much. We will be sharing the webinar, the recording of it, as well as the slide presentations, and we'll collect the questions and answers that were not, or the questions that were not able to be answered, and distribute them to the different presenters and maybe get a nice Q&A going for that. So thank you again to the participants for joining today, and please stay tuned. We'll have another program in about 2 weeks. So thanks so much.
Yeah, and thank you to all the panelists for a great job.
Thank you.
Thank you. Have a good evening, day.
Thank you so much.
Afternoon.